Hi, everyone. We are going to go ahead and get started. My name is Emily Sanders, and I am the project manager for the ACS Quality Verification Program, or QVP, here at the American College of Surgeons. We have a wonderful presentation for you all today, but before I turn it over to our speaker, I wanted to go over a few housekeeping items. We will have time for a Q&A session at the conclusion of the presentation. You can enter your questions into the Q&A pane on your Zoom toolbar at any time during the presentation. We'll try to get to as many questions as possible. This webinar is being recorded and will be available to you on our QVP webpage in the next couple of weeks. Hopefully some of you have heard of this webinar through our newsletter, the Quality Verification Update. This newsletter goes out quarterly and includes newly published articles, announcements regarding different ACS quality programs, upcoming webinars and events, and resources. This webinar is part of a new series of QVP webinars that will occur 3 to 4 times per year on topics related to the quality verification program. We would love to hear from you about topics of webinars that might be of interest and importance to you and your hospitals. If you scan the QR code on the screen, you'll be able to submit your idea for an upcoming webinar. I'll also put this up at the conclusion of the presentation today. Now, for the reason that we are all here today, we are so grateful to be joined by Dr. Rachel Kelz, who is the Executive Vice Chair of the Department of Surgery, the Director of the Center for Surgery and Health Economics in the Department of Surgery, and the Director of the Core for Precision Resource Utilization within the Center of Healthcare Transformation and Innovation at Penn Medicine. Dr. Kelz has focused her research on surgical outcomes, surgical education, and the eradication of surgical disparities. She has received private and public grant support for her work, has authored numerous chapters and more than 300 peer-reviewed manuscripts. Dr. Kelz has edited 2 books on surgical quality and safety. Dr. Kelz received her BS in mathematics from Union College in Schenectady, New York, her MD from Yale University in New Haven, Connecticut, and an MS in clinical epidemiology from the University of Pennsylvania in Philadelphia, PA. Dr. Kelz also earned an executive MBA from the Wharton School at the University of Pennsylvania in Philadelphia. Please join me in welcoming Dr. Kelz. Thank you so much for being here, and I will turn it over to you.
Well, thank you, Emily. I'm delighted to be here. I'm going to go ahead and screen share so that I can have the benefit of slides. Are you able to see my slides?
Yes, we can.
Okay, great. Well, first of all, thank you everybody for joining today. I think this is an exciting webinar series designed to really help you see real world opportunities for change by leveraging relationships across health systems and within hospitals. The rubric is all under the quality umbrella, but I will say that I'm going to focus my talking points today on healthcare transformation, which is, I think, a quality 2.0 endeavor. So we've spent sort of the last 20 years since the Two Eras Human Report came out, a little longer than that, trying to identify and educate surgeons and clinicians who care for surgical patients on quality improvement efforts and the idea of continuous quality improvement and a culture of safety. And I think the word is out. That's exciting. We have people now who are well experienced in performance improvement. And the problem is that the pace of increase in patient complexity and the demands on our time have increased probably faster than the adoption of a continuous quality improvement mindset. So we have to start to think slightly differently about the problem and how we can make it possible for surgical care to be delivered in a more efficient and effective, high quality way that benefits our patients and our workforce as well. So I'm going to highlight in the next half an hour or so our hospital's efforts from a different perspective outside of the usual quality lens on healthcare transformation using the best of the system. So just a few disclosures that are not really related to the content that I'm going to share, but I think are important to highlight. And as I mentioned, increased patient complexity, advancing technology, shortening length of stay, and declining margins all require healthcare transformation. In 2012, Penn Medicine developed a Center for Healthcare Innovation that was really designed to address new problems, old problems in healthcare delivery with new solutions. And in 2023, this endeavor was consolidated and reimagined and became the Center for Healthcare Transformation and Innovation. It's a conglomerate of 6 cores and centers, each with a slightly different focus, each with a slightly different capability, but all that are designed to work harmoniously to come up with simple solutions to complex problems under the umbrella of Penn Medicine. So we're working centrally to take information from our grassroots providers all the way up to the C-suite, and then take problems from the C-suite down to make solutions that work for the people and patients that are cared for and care for patients within our system. For the next for my presentation, I'm going to highlight one opportunity from the Nudge unit, and then I'm really going to spend the majority of the time talking about work performed for the Core for Precision Resource Utilization, which is an internal business pod that's designed to bring industrial productivity to academic medicine. And you can see here my collaborators in this endeavor are data scientists from industry and clinician scientists from within Penn Medicine, in addition to an industry expert and program manager to help make everything come to fruition. Innovation and transformation is needed across the 5 phases of surgical care, and I hope that you'll see over the next 30 minutes or so that quality and safety thinking is infused throughout everything that I do. I spent 20 years doing health services research. I still do that. I spent, 20 years doing quality and safety work, probably 25 years, if I'm honest with myself. And it's the understanding of all the different pieces and how they fit together that has brought me to the edge of transformation. So I'm going to talk about opportunities across the 5 phases of care, just giving some real world examples from things we've been working on at Penn Medicine. So starting with the preoperative phase of care, it's interesting to note that a large majority of adverse surgical events are at least in some way influenced by patient condition at the time of selection for surgery. So this means that if we don't get out in front of before our patients see us and start to think about how we can help referring physicians refer patients to surgery at a time that they will be most likely to benefit and least likely to experience adverse harm, then we're going to be missing a great opportunity. But you can't really talk about improving early detection of disease and early referral to surgery without talking about ways in which we're going to help surgeons manage an increase in surgical capacity and an increased need for surgical care. So I'm going to talk about 2 sides to the coin in preoperative phase of care: diagnosis and referral of surgical disease, highlighting a nudge experience, and then documentation and billing of consultations, highlighting new technology. So I'm an endocrine surgeon, and I, can't help but notice that it's easier to take out a small thyroid without event than it is to take out a very large thyroid or a complex metastatic thyroid cancer. And similarly, patients who have end-stage organ disease from their hyperparathyroidism have more challenges in their overall health than patients who are able to be spared from the end-stage disease because of early detection. So I'm going to talk about underdiagnosis and treatment of a surgical disease, focusing on the example of hyperparathyroidism. Less than a third of patients who meet screening indications for hyperparathyroidism are screened. And for those of you who don't know, hyperparathyroidism is most often a benign condition that affects one of 4 parathyroid glands and can cause problems with kidney disease, mental health. It can cause problems with the GI tract. It can cause bone loss, osteoporosis, and other end organ damage. And so it's important to identify patients with hypercalcemia who could benefit from surgical treatment, because it's an outpatient operation that's associated with a cure in 97% of patients with primary hyperparathyroidism. There are other forms of hyperparathyroidism that I'm not going to address in this context that are mostly related to end-stage renal disease. But in primary hyperparathyroidism, less than 40% of patients who meet criteria for treatment undergo surgery, and patients experience delays from hypercalcemia to treatment, which results in adverse outcomes. Why does this happen? Well, the volume of guidelines, tests, and results that our outpatient primary care workforce is expected to manage is outrageous. It's not suitable to the human mind, and we haven't really come up with good solutions to dealing with this increased burden um, of information that needs to be processed by each primary care provider. Furthermore, patients are able to access their providers more easily now because of the electronic health record, and this results in an increase in call burden, which doesn't necessarily result in improved patient care or patient satisfaction because there's a disconnect between the exchange of information and our ability to actually meet patients where they need us. So the nudge unit brings to the table a concept from behavioral economics, where which is the study of psychology as it relates to economic decision-making processes of individuals and institutions. And what that means is, how do we allocate resources? So the greatest example of a nudge is the McDonald's Supersize It campaign, which you may all be familiar with, where when you go to order McDonald's and you order your, burger and fries, and then they say, would you like to supersize that? And in so doing, they're able to increase their profit margins because profits are greater on larger volumes. And it's just a simple solution. And of course, when you say, do you want to supersize it? Well, who wouldn't want to make it bigger in America? So we borrow on these principles, and we are able to then break down the problem of delayed referrals into three different parts. One, do we correctly identify people who are screen eligible for treatment? Two, are we ordering the right screening labs? And three, is the provider able to interpret the labs correctly? And you can imagine, for a primary care provider or a specialist, it's nearly impossible to stay on top of everything that is required of them today. So providing clues in the electronic health record can provide a great benefit to them. And when we look at something like statin ordering, we know that embedding in the record patient information, it doesn't ask you to put in values. It actually takes the information from the chart and gives it to the provider already prepackaged, allows providers to make easier recommendations for the use of statins. So in this case of hyperparathyroidism, we developed an electronic phenotype of who should be screened for hyperparathyroidism. We then provide clinical decision support to aid in the identification of which studies are appropriate for which patient. And then we provide automated interpretation so that they can figure out what to do with the patient in a protocolized fashion, i.e. we standardize care. Do you send is the patient suitable for monitoring? Should they be sent to a surgeon, or do they need to go to an endocrinologist because they're a little more complicated? In implementing this three-pronged approach to earlier diagnosis and referral of hyperparathyroidism, the pilot studies showed very promising results with increase in using the innovative approach to screening tests being ordered in 75% of people compared to usual care, which was only 11% or 12% if you round up. We saw an increase in labs drawn and resulted that was in the order in which we would anticipate it to be, because this should really just provide us with the ability to see whether or not, when patients have the labs ordered, are they following through? So we didn't see any loss in follow-up. And then when we look at newly diagnosed cases of primary hyperparathyroidism with the innovative approach, we see a 71% increase in people who are being diagnosed compared to less than 20% in the usual care. So what this means is that streamlining guideline-based care in the outpatient setting allows patients to get to specialists in a timely manner and reduces preoperative risk. In the usual state of care, we were identifying roughly 2 patients out of every 100, and now we can identify 42 patients out of every 100 that need to be screened and referred. We then say, conservatively, if this translates into 30 cases, then we can increase our surgeon work RVU and revenue, and this allows velocity gains and enabled revenue. More importantly, it provides appropriate care to patients. The work done by the Nudge Unit that I've just highlighted is just one example of the work that they've done, and I'll highlight another at the very end of this talk to let you know that this is the way forward when we're dealing with increasing economic pressures, and we want to make sure that we're supporting the workforce, because medicine, and surgery in particular, is delivered by humans. And if we put too much strain on the system, we're going to actually shoot ourselves in the foot. And I think people on this call would agree that we need to develop solutions that are going to work for our providers so that they can take care of the patients in the way they are expert in doing without having to worry about some of the other barriers to care that have become a real nuisance. So along those lines, the Center for Precision Resource Utilization has developed a suite of precision resource optimizers that are designed to enhance care across the continuum of the patient's experience. So we go anywhere from the preoperative setting where people are trying to find a doctor all the way through to discharge destination for people who require hospitalization. We currently have 6 tools under development, and I'm going to highlight just a few of them today. No good story is complete without an origin story. So I just want to give you a little bit of background on how we came to developing the Core for Precision Resource Utilization. And you'll notice that I sometimes call it the center and I sometimes call it a core. It actually is a core within the Center for Healthcare Transformation and Innovation. And so I'm very proud of our residents within that center because that's what allows us to actually disseminate and scale across the institution. It also allows us to help other people battling other problems use our skill sets to develop new clinical decision support tools and also to evaluate new technology, which is critical to this discussion. So several years ago, in the context of research, I worked with a team of people to try to understand why it is that referring providers are not referring to high volume surgeons or people with the expertise that I would think of when I was going to refer a patient as a surgeon to a surgeon. So we did a qualitative study under the research umbrella, and we discovered something really interesting. When referring providers think about medications and make decisions between 2 medications for a patient, they're using decision support tools. And they do this because they feel that the evidence is clear. These tools are now often embedded in the electronic health record, so they don't have to search for them. And they find that they've led to easier decision making with decreased cognitive burden. But when you talk about how they decide which hospital to send a patient to for a surgical referral, they find that the data are unclear. They're not specific to the operation of interest. They're difficult to use and difficult to find, and there's nothing even within their own health system to help them make informed referrals. So they're basically left to rely on their prior experience, a surgeon's reputation, which we know is not necessarily correlated with outcomes, and convenience in terms of do they share an electronic health record with the provider or are they in close proximity? So using this information, we decided to try to develop a system where providers could identify the place within their own region where a patient would be most likely to achieve an optimal outcome of a colorectal resection, and to see if we simulated data on using real world data, whether or not this algorithm could reduce adverse events. And in this case, we looked at mortality. And lo and behold, we found that when we did a simulation study and sent patients to the place where the model predicted, and then compared the results to the place where they were actually treated, we saw a substantial reduction in mortality and an associated slight increase in cost, which to me is well worth the reduction in mortality. So in a conversation with members of our C-suite, this came up when we were talking about a patient who was going to go to a different hospital and then elected to come to Penn Medicine for a second opinion. And in the course of this conversation, the member of the C-suite was really interested in this and wanted to know more. And this is the origin story of the Core for Precision Resource Utilization. So essentially, we decided to start because they wanted to improve surgical referral so that we could make sure that every person who came to Penn Medicine for surgery, it was as if they had a best friend who was a surgeon who made their referral. So this approach really deals with a few things that were a challenge to the health system, which is why I think it resonated with the C-suite. Number one, when people were calling the call center had very limited information to use when deciding how to refer that patient. Number two, surgical complications are costly, and malpractice in Philadelphia is a disaster, with no constraints and no in my opinion, no real association between payouts and the harm. And so this is a real challenge to the healthcare system. We've seen this in other areas like obstetrics, and it's of concern across all hospital systems within the state of Pennsylvania. And then the other issue is our surgeons are frustrated because their profiles that are on the web don't necessarily reflect their expertise. So they'll see patients in clinic who aren't really there for them because they chose them as their surgeon based on inaccurate information. And the patients that they want to see in clinic aren't necessarily coming in because that's not on the website. So we developed FRED, Friendly Referrals Informed by Data, and we are able to see within 4 proximate hospitals within our own system where is a patient most likely to have the best outcome with the lowest likelihood of an adverse event. And this system also allows the referring provider to look at what is driving the patient's risk and to see if there are any modifiable risk factors so they can play with the system, and then they can say to the patient, oh, it looks like if we're able to control your diabetes before your operation, we're going to reduce your risk by X%. Well, we were really excited about this, and we couldn't imagine how in the world like this wasn't going to be the best thing that you could imagine for referring providers. But it turned out that the system was not ready for this level of complexity. The amount of time that it was going to take to onboard everybody far outweighed the amount of time that people had to think about this. And so we had to pivot. So in order to try to achieve referrals as if everybody has a best friend who's a surgeon, we went to what is already known in the literature as a standard. And we chose to focus on provider volume. It is true that you can have high volume surgeons who have bad outcomes, and you can have low volume surgeons who have exceptional outcomes. And the outcome is definitely the true north. However, we have to find a way to improve the likelihood that a patient is going to go to somebody who has the expertise that they need. And volume is one of the best signals that we have to do that easily. So this table shows, just using an example of one particular operations, the distribution of an individual surgeon's experience with that particular complex operation compared to their overall volume. And you can see that we have very focused surgeons who specialize in one domain and do just a little bit of other things. And we have very general surgeons who do just a little of one complex surgeon and have a ton of other business in other areas. And we can see that depending upon the operations, roughly 1 in 5 to 1 in 10 patients treated within our health system are treated by a low volume provider. So if you think this is a valuable metric, then there's an opportunity here. So what we also did is we looked further, and we found that publicly available information on surgical expertise within our system is often inaccurate. And you can see here a tool that on the left-hand side of your screen is how you could find a surgeon if you're looking for someone in Penn Medicine. And you could put in a search term like thyroidectomy, for example, and all of these providers would pop up. And what it basically tells you is that all you would see is all these providers without the shaded information. But what we know at Penn Medicine is that we're already giving you misinformation because the gray providers are affiliated, but they're not part of our faculty. The Cope and Blue providers are not even surgeons. So there's inaccuracy in what we're pushing out to patients. So what we've done is we designed a project called SCOPE, which is Surgeon Claims and Outcomes for Patient Excellence. And we basically are doing some very sophisticated data wrangling to create a surgeon profile that will allow us to use the information that's contained in all of our billions of data points in order to get patients to the surgeon that's most likely to meet their needs. So first, what we've done is we're using this information to work with our marketing and technology teams so that we can inform our Find a Doc software so that it will actually allow you to see this doctor is high volume, this doctor is accepting patients and may be new to the system, so we don't have adequate information of them, but have the expertise that we think that they would be a good surgeon for you, or this doctor is not high volume in this specialty. So everybody's name will go up there. If your referring doctor sent you to Dr. Z, you'll at least be able to see that that person, although wonderful and many things that that your referring doctor may be using Dr. Z for may not be right for the operation that you need. You can still go to Dr. Z. You have total autonomy in terms of who you select as the patient, but you may want to either discuss with your referring provider or just consider going to Dr. X or Dr. Y, who is recommended from within the health system as somebody as high volume. The other thing that we can do with this is we can now take the information from the patient claims and office visits and optimize what we show people on the website. So take this one surgeon, for example. Before optimization, you can see that their expertise included things like bile duct cancer or cholangiocarcinoma, in addition to insulinoma and laparotomy. Well, I happen to know that this surgeon is a thyroid and parathyroid surgeon who treats complex thyroid cancer and difficult parathyroid conditions, but does not do anything related to cholangiocarcinoma or intra-abdominal surgery. So after optimization, what you see comes up is based on this person's actual history of patient care, and you can see that this more closely aligns with what I've told you about this surgeon's practice patterns. So this benefits both the surgeon themselves, because now they're not seeing patients who they have to call a colleague to see if they can see them on the same day for patient convenience, but takes time out of their day in clinic and takes a new patient spot in clinic when they could have been seeing somebody they could actually have helped directly. And similarly, it allows them to tell people what they specialize in. The exciting thing about this, which is on the horizon and will resonate with everybody on this call, I think, is that it might allow us to become more reactive and become proactive or generative. We may be able to develop programs where we can allow surgeons to develop their expertise under a proctored program, where if they're not a high volume pancreas surgeon, for example, but they really want to be one, then they could highlight themselves as somebody who needs a proctor. They can accept the patient with the proctor, and that would mean that they would have to begin the care of the patient with a pre-operative discussion with an expert in the area who is high volume. That person will be available with them for the critical portions of the operation as they're ramping up their own independent volume, and then they would discuss with them the post-operative management, especially should anything untoward occur or unexpected. So this allows us to improve quality and build capacity, making sure that we don't have the waste of inappropriate referrals and patients having unnecessary complications. If we're going to ask our surgeons to increase their patient volume because we're going to increase and streamline the access to care, we have to come up with ways in which we're going to simplify what it takes for a surgeon to safely take someone to surgery. There are new technologies on the horizon, and we're excited to use them at Penn Medicine. One technology, for example, is ambient listening. A lot of people think this is just a speech-to-text capability, but it's more than that. It actually is able to take a conversation that you have with a patient in the office and translate it into a note. I use this technology in my office, and I and a net promoter score, which is something you use to say whether or not you'd refer somebody to use this technology, gave it a 0 when I started, and now I'm up to a 7 or an 8. It actually makes it a lot easier for me, and I can still have that human discussion with a patient, sharing individual vignettes from my own life experience or their life experience, laughing a bit. That stuff doesn't make it into the note. The stuff that makes it into the note is crafted by AI that filters out that human connection, that stuff that makes the patient comfortable, but allows me to be myself with the patient and yet generate a note without having to do all the work in front of the patient or on the back end. The other thing that's interesting about some of these technologies and others is that we can now also help with accurate coding and improved documentation to allow us to capture case complexity. So one of the most frustrating things about the transition from paper notes to electronic health record, which I can attest to as a person who lived through that experience, is that you used to be able to check boxes on a templated note that allowed you to always pull forward with you what was relevant about that patient's history into what you were going to do when you were taking care of them. And now you have to populate things, and then it asks you to re-clarify it, and it just made it really frustrating and complicated. But with natural language processing of your documentation with the patient, we can actually improve documentation. And what this means is that the ambient listening piece, as one example, can improve physician satisfaction because it's associated with an increased rate of same-day chart closures and a decreased amount of pajama time for the patient in the electronic health record, which means that Monday through Friday from the working hours, people are able to get their work done instead of having to do it at nights and on the weekends. The other thing is it leads to a slightly better patient experience. At least we are only demoing this to start, but the patients like being able to just look face to face with you without you being in the electronic health record the entire time that you're documenting. It also improves quality because it makes sure that more of the comorbid conditions are captured, and it's revenue enabling actually because it can help you to better capture the categories of risk that allow you to increase to get credit, I should say, for the severity of illness that your patient brings to the table. And in only one of our disciplines, we identified a $4 million opportunity for revenue generation, just making sure we captured the case complexity that was actually being treated within our own organization. So it's not coconut shells here. It's actually just saying you're doing the work. Let us on the back end help you get credit for it, because it's too much work to ask the clinicians to do everything it takes to get the billing credit. We need to do that on the system side. That needs to be our, our axe to grind, our boulder, our burden to shoulder. So moving now into the intraoperative phase of care, we address two things with CPRU, the Core for Precision Resource Utilization. One is we're working on schedule optimization, and the other is the recognition that there are human factors that are necessary to transform some aspects of care. So I'm going to start with schedule optimization and the fancy stuff that we're able to bring through this to the system. And keep in mind, the majority of this work was done by 2 data scientists brought from industry. So we're not talking about a large expense here, and yet the revenue generation from just the tools they're able to generate and the improved experience for patients and providers far outweigh the cost of this endeavor. So what we noticed was that in 2023, more than 42% of our case length estimates were more than 30 minutes off at our flagship hospital. And obviously, this leads to a lot of waste and patient and provider dissatisfaction. So working with our perioperative leaders, we developed a model in silico, meaning that just, we used real world data, but we didn't use it in the real world. And we were able to develop a model that could outperform our electronic health record. It also outperforms the electronic health record plus the 4 FTEs that it currently takes to massage the schedule after the electronic health record spits it out. We also look over time and we find that Oracle, which is what we call our model, continues to outperform with smaller absolute errors compared to either other method. But we also found that there was a change in the model from the electronic health record that took place in September that made that model go completely out of whack. And that wasn't reported to the users. And so one of the things that I want to highlight here is that when you do it internally, or you at least sustain internally, you can keep track of when there are tweaks to the system that may really run havoc with how you're doing your scheduling. So what you can see here on the right-hand side of your screen is that before Oracle and after Oracle, we see a sharp reduction in the amount of cases that are scheduled with more than 30 minutes of inaccurate time. What this might translate to, and I say might because this is new, so I don't want to overpromise, but what it might translate to is 135 OR days saved, meaning that if we could figure out a way to use the accurate case length predictions to allocate the schedule appropriately to the times needed, then we could actually capture increased capacity within the system. And just to note below, you can see that comparing machine to machine, the average absolute error per case in the electronic health record is about 79 minutes, and with Oracle, it's only 35 minutes. So this is really the future. But to do this, we have to address the many real-world constraints that have to be considered when building the final schedule. And at our flagship hospital, it's incredibly complicated because within the one complex, we have 4 different operating room spaces where true operations can be performed. It doesn't include interventional radiology, interventional cardiology, and endoscopy, where procedures are also done and could benefit from this technology. But just in the operating room space, we have 3 separate spaces, and then we also have 4 separate spaces, and then we also have the complexity of who can go in what rooms, and some rooms that are only fit for certain things. And with the advent of MIS technology, we have the availability of robots in some rooms and not others. So it's really complicated when you think about this stuff. So we're developing Boost, which is better operative organization for surgical throughput, which uses our past OR schedules to simulate rearrangements and see if we could optimize the schedule. And in one experiment where we just looked across 3 services, we were able to potentially reduce overtime by 10%. And I use that metric because here, overtime is important because it means our people going home on time, and it means our surgeons too. Gone are the days when people want to start their last case at 6 p.m. and go home at midnight. So we have to make a way where we can deliver safe surgical care, and we know that it is safer to start elective operations before 5:30 in the afternoon. And we can deliver better surgical care that allows our workforces to feel good about what they're doing, because we have real challenges with workforce satisfaction in the modern day. So I did say I was going to talk a little bit about human factors. Turnover time is primarily a function of human factors. A machine cannot do this for us. So we have to figure out a way, and different ways will work in different contexts, to improve turnover time, because that's part of the equation for getting home on time. So this is just my experiment in our own health system, where I compared turnover time in our ambulatory surgery center to turnover time in the main OR where I practice. And granted, the cases that are done in the surgery center are slightly different than the cases that are done in the main OR, but nonetheless, the turnover time should not be so dramatically different, because what it translates into is an hour and 26 minutes a day of unnecessary waste. And if you look at being able to end the day on time versus not, this is the considerable difference. So I just want to suggest that by going in and doing a morning briefing to set expectations and align expectations at the start of each day, begin turnover before the room is done. So when I'm done with my portion of the case and turn the case back over to the anesthesiologist for emergence, I want to give them all the time that they need to do that safely. But I can start taking the linens out. I can start taking out the trash. So I start that time along with our circulating nurse now, as long as they're done with their timeout. And then we communicate during turnover. And then we review and reflect on what we could have done better. And we work with our environmental services partners, who we make sure to acknowledge and thank for the hard work that they're doing and the care that it takes in the process that it takes to care for our patients. And by doing this method, you can see on the graph on the right that we've been able to gain 36 minutes back per day. So it's not quite an hour and 36 minutes, but it is substantial. Another low-tech solution that we've brought into the operating room, I wanted to bring up here just briefly, because one of the things that's going to be coming to the future is these radio-labeled, radio-guided surgery. It's already happening with autofluorescence of certain tumors and the ability to identify critical structures by fluorescing them in the operating room. But not everybody's going to have the resources to invest in those technologies. In what I do, the recurrent laryngeal nerve is sacred. And so one of the things that I learned to do that I learned from the literature is that one of the differences between an expert and a novice is their ability to track the nerve. So I always work with residents, and I want to make it easier for them to go from novice to expert. So we've started to use a non-toxic marker to highlight the nerve during the operation, and you'd be surprised at how much easier it is for them to find the nerve and continue to keep it in mind during the operation. So this intra-op phase of care allows us to mitigate risk and improve the patient experience and the clinician experience. The final example that I want to share with you today is an example from the post-operative phase of care. So the Minnesota Hospital Association said hospitals and health systems lost $487 million due to delayed discharges in 2023 alone. I mean, that's extraordinary. We do not have the margins today to lose this kind of money due to things like pre-authorization. So we've developed an AI discharge prediction program to allow us to identify in the day of admission whether or not a patient is going to need to go to SNF or acute inpatient rehab. And it's an incredible model. I'm not going to bore you with the scientific details, but if you like them, I'd be happy to set up a meeting to talk with you about them. But basically what it's allowing us to do is reimagine how we handle these discharges. We can learn from the comprehensive joint program that if you get a social worker or case manager in to talk to the family and patient early about the idea of going to SNF or acute inpatient rehab, families are accepting. They want their loved one to have the smoothest recovery to home. But if you go to talk to them late in the day, there's often a lot of hesitancy on the part of the patient or the caregiver, because they think that you're throwing them out of the best place for them, the hospital, in exchange for somewhere that you don't have to think about them. And that couldn't be farther from the truth. It's just an inpatient hospital in a skilled nursing facility or acute inpatient rehab offer different skills and resources, and patients need different skills and resources at different stages of their recovery. So part of this is about us educating people on what would be best for them at different stages of their recovery. The other part of this is that if you approach this earlier, then you can develop pre-authorization programs with your local insurers so that you don't have to wait for the authorization to come through once the provider says the patient can now go. But you can actually get a pre-authorization early so that if the provider says the patient is ready to go and they still need to go to SNF or acute inpatient rehab, you've got your pre-authorization and the patient can go as soon as that bed is available. You can actually partner with the SNFs and acute inpatient rehab also one step further to make sure when the patient's ready, that patient can go. So this is a way to really consolidate that waste and get rid of it. It's a really exciting concept, and it has a lot of our teams excited about it. The other thing about it that's neat is that it involves our other service-oriented partners in case management and social work to really engage with their patients earlier and to also give them a solution to a problem that frustrates them. Furthermore, it doesn't remove any autonomy or expertise from the provider, the surgeon who's taking care of the patient. The doctor taking care of that patient is still responsible for deciding when it's appropriate for them to transition their phase of care. And so it's important that we recognize that we're just asking the doctor and the surgeon to continue to do their job per usual. And it's just, we want to make it easier for them so that once they say it's time, we can make it happen, as opposed to then saying, okay, now you still have to figure out how to provide the next level of care to this patient that's outside of your expertise while they wait to get a bed. So overall, the rapid discharge program has the potential, and again, here we're talking potential, to lead to a better patient experience with a faster recovery and build capacity with shorter wait times to inpatient care. It's important to note that there are barriers to implementation for all the programs that I'm talking about, and that you have to consider them. I put this here so that you can understand what some of the barriers to implementation are, in particular for the adoption of new technology and AI. But these barriers and implementation are no stranger to those of us involved in quality and safety work, because we are always challenged to think of them in advance when we're designing our algorithms for improvement. In conclusion, it's important that we look across the 5 phases of care for opportunities to improve surgical outcomes. Better local control will lead to better long-term outcomes, and using artificial, assistive, automated, and augmented intelligence will provide substantial transformation to surgical care and allow us to achieve the quality improvements that we are aiming to deliver. One short transgression back to the Center for Healthcare Transformation Innovation that I promised at the start. The Center for Healthcare Transformation Innovation is proving to be a must-do for, in my opinion, most health systems. In just a small bit of time, there are $106 million in grants and awards, 75 solutions that have been implemented, and 560 publications that have come out of this endeavor. 2 examples that I wasn't able to highlight today include one where the nudge unit created 1 hour of work in a simple nudge that resulted in $32 million in savings for Penn Medicine. That has to do with generic prescribing habits. And another one in surgery that I wasn't able to highlight includes a digitally enabled postoperative care model for breast reconstruction, which eliminated 3 to 4 in-office visits for post-surgical patients and increased access to a very coveted service, our plastic and reconstruction team, so that we can get new patients in a timely fashion, and we can allow other patients to save 5 to 6 hours a day, 3 to 4 times during their recovery period by eliminating these unnecessary office visits. So I have to express thank you to the Center for Surgery and Health Economics that developed the impetus, which was the origin story of CPRU. And otherwise, I'd like to thank you for your time and attention, and I'm happy to take any questions.
Thank you so much, Dr. Kelz, for that presentation. We've had a couple of questions come in, so I do want to get to those. But before I do, I just want to bring your attention to where this webinar is going to be on the QVP website. It's going to be under this webinars and videos tab. So in case you had to join late or leave early, this webinar will live on our website. We also have a great resources tab that has a variety of materials related to QVP, including a standards quick reference guide, sample site visit agendas, and information about our ACS quality improvement course. So I just wanted to bring your attention to that. But let's get to some questions. We had a question come in from Levon, who asked, can you share more details about the parameters within simulated rearrangement?
Um, I'm not totally sure about what you mean about the parameters, but I can say that there is an article linked in the slide in that slide that will be on the webinar that you can look at to see the actual processes that we use to do the simulation. But in general, we do our simulations with different thresholds of travel distance, so that we simulate, you have to go within 30 miles of your home zip code or within 120 miles of your home zip code. More modern work that we're doing focuses only on travel time. The other simulations that we do are restricting simulations within single hospital systems. So because of some insurance requirements, certain patients are capitated to certain systems for care. And so we would simulate just within the systems to make sure that we respect the boundaries of what an insurer might mandate. Those are the types of parameters that we used for the simulated rearrangements. I'm not sure if that answered your question, but if not, I'm happy to take another stab at it.
Thank you for that. Yeah, Levon, she said that did answer my question.
Thank you.
Great. If there are no other questions that have come in, I thank you. I can give a few more minutes for questions, but thank you again so much, Dr. Kelz, for this wonderful presentation. I am going to share my screen one more time. And just if you have any interest in suggesting our next webinar topic, something that would be of interest or use to the hospital that you work at, or any questions regarding the quality verification program, please scan the QR code on your screen. And if there are no other questions, everyone, I hope you have a wonderful rest of your day. And again, thank you so much to Dr. Kelz for your time and presentation today. Oh, we did have a quick question come in.
Oh.
Is scope nationwide?
Scope is restricted to within our hospital system at the moment, but we're developing it in such a way that it will be interoperable and easy to transfer across entities.
Great, thank you.
Thanks so much, everybody. Have a great day.
Thank you, Dr. Kelz.